So patient with long-term SOB, my thought would be pulmonary fibrosis. In the case of pulmonary fibrosis, as other differential include tuberculosis, lung cancer, and heart failure. In terms of firstly, if my top differential is pulmonary fibrosis, then I will have a general inspection. So before I proceed with the examination, I would like to identify my main aim of the examination, and the main physical examination that I would do. Number one, I would see signs of pulmonary fibrosis. Number two, I would look for signs of complication. And number three, I would look for signs of cause of the pulmonary fibrosis. Signs of complication include right ventricular heart failure. So I'll be eliciting any fluid status, status as well. Inspection, generally do vital to assess the in terms of the overall oxygenation, vitals, cool, if there's any heart failure. So important to do vital, CRT, and then nail, have a general inspection. Just like to see if there are any joints due to connective tissue disease. Then I would do CRT, temperature for perfusion status. Here, pulse. Okay, and then proceed with clubbing. Patients do clubbing. Important in pulmonary case, especially pulmonary fibrosis is very important. And then I will have a look at central cyanosis to look. This is indicative of heart failure due to impaired perfusion status, which means that there could be complication. Then I will lie down the bed at 45 degrees, open the shirt, general inspection, so just general inspect, just palpate. Respiratory should be less. Palpate just do the trachea status, not really significant here, I think. Palpate, is that back speed for any displays, for example heart failure. Actually I would like to move first to the posterior part. That would be my focus. So ask the patient to sit forward. Ask the patient to sit forward. Look at their side. Hug the pillow. Hug the pillow. Inspect. Should be reduced. And then I'll just percuss. Should be the same. Resonate the same. And I would auscultate. Auscultate, compare, look for inspiratory crackles, late inspiratory crackles, velcro like sound. One of the most important thing would be to identify where is the location, because that could help me with the differential diagnosis of what causes of fibrosis that can be at the base or at the top of the lungs. Then asked to do vocal resonance 99, and that's about it. Then I would feel for any sacral edema, and I would do lymph nodes because I'm thinking of TB. and cancer as well. And after that, I would do forward. I would start with the maintain the 45 degrees. I would do cardiovascular first because I've already elicited the pulmonary at the back, so my main focus would be cardio examination. Heart sounds. First, focus on the heart sounds. Or lepas tu take money, and take money, and also I like to do the specific maneuvers of murmurs. But that is not the main significant point here. The main thing is to check if the heart sounds fine, if there's any signs of heart failure, which means that there is displaced apex beat ataupun effusion or S3 S4, and if there's any murmurs lah, I will try to elicit murmurs as well. And then forgot this now, I would also check the patient's JVP. To look is indicative for right ventricular heart failure. And then generally, if the patient has an underlying condition such as rheumatoid arthritis, I would check on the joints. If the patient has back pain, ankylosing spondylitis, systemic lupus, have a look at the joints and the associated clinical features, sarcoidosis. That would be my additional examination in the last 2 minutes to look for those signs. Essentially, I need to check for ascites as well. Ask the patient to lie flat. Just like to do shifting dullness. Check for any edema on the leg. And that concludes my examination.